Good evening, doctor. Please welcome our today's virtual webinar speaker, Dr. Sneha Kothari. Dr. Sneha Kothari is a global and consultant endocrinologist from Global Hospital. Ma'am presented various publications in various journals. Today, ma'am will speak on all-round intensification of glycemic and non-glycemic benefits to level with diabetes. Basically, ma'am will speak on fixed drug combination of sitagliptin, dapagliflozin, and metformin. Ma'am, session is hand over to you, ma'am.
Yeah. Good evening, everyone. Thank you, Sun Pharma, for organizing this important session about the fixed drug combination. We know that the treatment of diabetes has revolutionized with the introduction of DPP-4 inhibitors in 2009 and then SGLT2 inhibitors. And with dapagliflozin going off patent, we see many patients being prescribed SGLT2 inhibitors more and more often because cost constraint has gone down the cards. Coming to our session. So today's session is how to do the intensification of diabetes management with the newer drugs, and if these newer drugs are just glucocentric or they do help us to control the metabolic parameters and are more cardiac and renal beneficial or no. So today's talk will help us know about those important points. So our session will be divided into why we need to intensify diabetes management, what is the approach to combination therapy in diabetes management, what are the recommendations for the use of combination therapy, and what are the benefits that this triple drug combination of sitagliptin, metformin, and dapagliflozin offers beyond just glycemic control, and how is it beneficial, and what are the key take-home messages. So starting with the first point, that is need for all-round intensification. Now we all know that diabetes is a big burden. We are gradually becoming the diabetes capital. If we see globally, diabetes is the ninth leading cause of death, and majority of the patients with diabetes end up having cardiovascular disease or chronic kidney disease. For that matter, in a patient even with chronic kidney disease, the reason for morbidity and mortality is usually cardiac. And the reason why we are getting more and more diabetes is because of our obesity and unhealthy lifestyle, sedentary lifestyle, eating all processed food, junk food. So if we see in India around in 2019, 77 million people were suffering from diabetes, and this number is expected to rise to 134 million. So if we see the amount of morbidity, mortality that we'll be facing in our future, it's among us. So we need to look at the treatment of diabetes, which is more safe, less risk of hypoglycemia, and which patients will accept because hypoglycemia is one of the biggest hindrance in the diabetes intensification. Another thing is we need a drug which is not only helping us to control our blood sugars, but it is also helping us to control metabolic parameters that come along with diabetes, like obesity, hypertension, dyslipidemia, without the risk of hypoglycemia. So that way, more and drugs are being used. Now, coming to what is the status of the glycemic control in Indian patients. As like any other country, I think majority of the patients do not reach their HbA1c targets. Not only they do not reach HbA1c targets, important thing is only 20% of the patients know they have diabetes, and out of the 20%, hardly 50% would be having adequate glycemic control. The current guidelines say you target HbA1c based on the patient's morbidity and comorbidities. But if we see even in a young diabetic, how many of the patients coming to the OPD would achieve an HbA1c goal of 6, 6.5 without hypoglycemia? Studies have clearly shown that the starch consumption, like the starch study which was published, showed that the starch consumption in the Indian patients is very high. Rather than 50-60% of the food which should be carb based, it's around 70 to 80% of the meal fraction is carb based. And if we see glycemic control, see here around 50 to 70% of the patients do not achieve HbA1c goal of less than 7% or fasting sugar goal of 70 to 130 and post meal glucose less than 180. This has been clearly shown in various studies, including ICMR INDIAB study, TIDE study, and study which was published by Dr. Shashank Doshi in START study. So if we see only 30% of the diabetics are in their glycemic goals. How does this translate in our day-to-day practice? We all know that uncontrolled diabetes can lead to lot many complications. Diabetes is a disease which can affect from toe to tip to toe. So it's a disease which can lead to all complications. About 30 to 40% of diabetic patients suffer either from cardiovascular disease or chronic kidney disease. The risk of microvascular complications increases as the duration of diabetes goes up. And if patients have uncontrolled diabetes, studies like UKPDS and DCCT have clearly shown that the risk of complications is much higher. Now, coming to the status of cardiovascular health in a patient with type 2 diabetes, we all know that diabetes is considered as a cardiovascular disease risk equivalent. So, patient with diabetes, even without other risk factors for cardiovascular disease, is always at a higher risk of developing cardiovascular disease. And we all know that in obese diabetes, diabetic patients usually have, along with diabetes, hypertension, dyslipidemia. So all these factors compound and increase the risk of cardiovascular morbidity and mortality. Not only the cardiac complications go up, but diabetes has shown to increase the risk of stroke also to the by 2 to 4 fold. In addition, diabetes can lead to diastolic dysfunction, and majority of the patients who present with heart failure with preserved ejection fraction have diabetes as an underlying risk factor. So diabetics are 2 to 4 fold more prone for the cardiovascular disease, that is atherosclerotic cardiovascular disease, and eightfold increased risk of developing heart failure. And managing diabetes may help to prevent these complications. Now, coming to renal health in the patient with type 2 diabetes, we all know that the major reason for kidney failure in a in India is diabetes. And diabetes, along with uncontrolled hypertension, has shown to increase the risk of progression. So, the commonest reason for kidney failure in India or abroad is diabetes. The reason why we are seeing more and more uncontrolled diabetes is because there is a reluctance to increase pill burden. So average HbA1c that we see in patients with diabetes is 9 to 9.5%. Our goal is to achieve HbA1c of 7%. So in a patient who comes with diabetes, with the new onset diabetes, suppose the HbA1c is 9, such patients are not going to respond to a single drug. We know that each drug reduces HbA1c to the extent of around zero point 0.6 to 8.8%. So if a patient's HbA1c is 9 and your goal is to achieve 7, definitely such a patient will need triple drug combination. So the reason for this reluctance is to increase in the pill burden because it increases the cost, inconvenience. They have to take dosages at different time of the day. One drug needs to be taken in the morning, another in the afternoon. So when we combine the medications, it reduces the risk of pill burden and it is easy for the patients to remember. So a section 2 deals with how do we approach the combination therapy. Now, studies like DCCT, UKPDS have clearly shown that better the glycemic control at the diagnosis of diabetes, lesser the risk of complications. What we call as metabolic memory. The memory of poor or a good glycemic control remains in the cell for all their life. So, a patient who is diagnosed with diabetes and says, I have no symptoms, let me take care of my sugars after 5 years, as against a patient who has been very, strict in his sugar control at diagnosis, the risk of complications will be much lesser in the patient who has had early aggressive sugar control. So, what we need is early and more aggressive treatment of diabetes, achieve a good glycemic control. And once patient has attained into the glycemic goal, what we needed, then we can slowly taper down the number of medications. And this also reduces the risk of becoming insulinogenic in future and also reduces the risk of complications. So if we start a patient on a minimal drug and gradually as HbA1c goes up, we keep on adding one odd drug. The risk of the glycemic control is not very great, and the risk of complications is much higher. So UKPDS and DCCT have clearly shown act quickly, act aggressively, control the sugars at diagnosis very well, and reduce the risk of complications in future. So the same thing, UKPDA showed that reduction of HbA1c by 1% reduced the risk of all micro and macrovascular chronic complication. It reduced the composite endpoint of any diabetes related event by 12%. So HbA1c in intensive treatment was attained to the tune of 7% as against conventional treatment, which was 8%. So even that 1% reduction in HbA1c made a huge difference. And now we have many drugs which can help us achieve this glycemic goal without putting the patient at the risk of weight gain, cardiac failure, pedal edema, or putting the patient at the risk of hypoglycemia. So let us see what are the recommendations for the use of combination therapy in diabetes by various authorities. So American Association of Clinical Endocrinology, that is ACE 2020, recommends that this was the first guideline which mentioned the treatment of diabetes based on the HbA1c. What do they say? For a newly diagnosed person with diabetes and an entry HbA1c of greater than 9%, or if the HbA1c is more than 1.5% above target, one should initiate, along with lifestyle modification, dual or possibly triple combination pharmacotherapy, usually in combination with metformin. So this is important. Keep in mind each drug reduces HbA1c by zero point 0.6 to 0.8%. If we have to achieve HbA1c goal and reduce HbA1c by 2.4 2.5%, then definitely this patients need triple drug combination as against a single drug for achieving the glycemic goals. Same way, what does ADA say? ADA says that early combination therapy can be considered in some patients at treatment initiation to extend the time of treatment failure. So ACE was the first guideline which said treatment of diabetes based on HbA1c and promoted the combination therapy. What does ADA and ESA 2022, ESD 2022 recommend? It says that combination therapy increases the durability of glycemic effect and there is potential to address the therapeutic inertia. It reduces the impact of medication burden. It improves the adherence and has treatment persistence also. By using combination therapy, you are targeting multiple pathophysiologic processes characterized by type 2 diabetes. And in addition to just being glucocentric, it can be more metabolic centric, cardiocentric, and renal centric. So, what does our own RSSDI 2022 recommend? So, it says that if glucose targets are not achieved with two agents, start the third oral agent. It can be either glucobay or voglibose or a DPP4 inhibitors or an SGLT2 inhibitors or thiazolidinediones or oral GLP-1 receptor agonists depending on the second line agent being used. For the patients who have established atherosclerotic cardiovascular disease, has diabetic kidney disease, or has heart failure, or needs weight reduction, in such patients, oral GLP-1 analogs and SGLT2 inhibitors are the treatment of choice. For the treatment of postprandial hyperglycemia, alpha glucosidase inhibitors, glenites, or SGLT2 inhibitors should be considered if not contraindicated. In elderly patients with an increased risk of hypoglycemia, use a DPP4 inhibitor as an alternative to sulfonylurea. Now, coming to the third part of our talk, which is the use of triple fixed drug combination therapy. How does it help in intensifying the glycemic management and what are its non glycemic benefits? Now we know that Dr. DiFranco has given a classical omnious octet pathway. So when we are using triple fixed dose combination therapy, we are targeting multiple pathophysiologic pathways. We are reducing the pill burden. By improving glycemic control, we are reducing the risk of complications. And because the pill burden has come down, the cost comes down and definitely there is improved compliance. So, how do SGLT2 inhibitors offer favorable outcomes in triple drug fixed dose combination compared to thiazolidinediones? Thiazolidinediones means are pioglitazone and now the newer one like lobeglitazone. So if we compare HbA1c reduction amongst thiazolidinediones and SGLT2 inhibitors is more or less same, around zero point 0.8 to 0.9%. But if we see the main difference is weight gain and hypoglycemia. Weight gain is not seen with SGLT2 inhibitors. In fact, they lead to around 4 to 5 kgs of weight loss as against thiazolidinediones, which lead to weight gain. So HbA1c reduction wise, they are more or less same, but as far as metabolic parameter like weight gain is concerned, definitely SGLT2 inhibitors score better over pioglitazones. Another thing is pioglitazones cannot be used in a patient with a history of underlying cardiac failure because these drugs lead to water retention and can worsen cardiac failure. In addition, usually obese diabetics are more prone for osteoporosis, and we know that pioglitazone has been associated with the risk of fractures. Also, if the patient has underlying diabetic retinopathy or has a macular edema, pioglitazones have shown to worsen that. So, these are subtle advantages of a fixed dose combination of metformin and DPP4 inhibitor or sulfonylurea with SGLT2 as compared to thiazolidinediones. Now, how does DPP4 inhibitor offer comparable efficacy? We all know that our meal is carb-based meal. Postprandial hyperglycemia is very well known. So efficacy of DP4 inhibitors is higher in Asians we obese diabetics usually have lesser amount of GLP-1 in the body, and sitagliptin or the DPP-4 inhibitors have shown to improve the amount of GLP-1s through incretin effect. So effect of DPP-4 inhibitor is almost comparable to that of thiazolidinediones or SGLT2 inhibitors. Now, what can be a second and a third line agent for a fixed drug combination? We know that we are insulin resistant country, so for the same amount of body mass index, the amount of fat that we have is almost double, what we call as thin fat Indian, the famous YY paradox. Now metformin definitely remains the first line pharmacological approach, though the current guidelines say, SGLT2 inhibitors, GLP-1 analogs should be written in patients who have DKD or underlying heart failure, cardiovascular disease. But I think in Indians, even that touch of a 500 milligram of or 1 gram of metformin does magic to the control of diabetes. So definitely metformin remains the first line pharmacological agent. Now coming to second and third line agent, definitely SGLT2 inhibitors and DPP4 inhibitors can be considered as second or third line agents due to they have higher HbA1c reduction, they have proven cardiovascular safety, proven renal safety, and most important is the risk of hypoglycemia is minimal and they help in weight loss. So definitely they can be considered as a second and a third line drug for the intensification of diabetes management. Now coming to SGLT2 inhibitor, DPP4 and metformin fixed dose combination. Why is it an optimum option for Indian type 2 diabetics? We all know that we are carb based. Our main problem is postprandial hyperglycemia. So if you see in a Monod's hypothesis, at HbA1c more than 9, it should be fasting glucose that contributes more to the HbA1c as compared to PP. But in Indian patients, even at HbA1c 9 or 10, it's a postprandial hyperglycemia that still keeps on contributing to the higher HbA1c. So we all know that SGLT2 inhibitors and DPP4 inhibitors work on postprandial hyperglycemia. So this triple drug combination attains safer, rapid, and sustained glycemic benefit, helps in reducing blood, body weight, and blood pressure. It improves insulin resistance and beta cell function, reduces pill burden, and improves overall cost effectiveness. Now coming to section 4, same thing, it is acting on the multiple pathways of omnius octet. So omnius octet on the pancreas, basically the DPP4 inhibitors work to improve insulin secretion and they decrease glucagon production. They can at times reduce beta cell apoptosis. Metformin works on the liver to reduce hepatic glucose production. It works on the muscles to improve glucose uptake postprandial. In addition, it has shown to inhibit lipolysis. Coming to SGLT2 inhibitors, they work on the small intestine and on the kidneys to reduce the reabsorption of the sugar. So that is how the drugs have been acting on multiple pathways and help in the control of glycemia. So the glycemic pentad for effective glycemic control, that is fasting plasma glucose, postprandial plasma glucose, HbA1c reduction, glycated hemoglobin control, and quality of life. Everything has been taken care of, and because they have a lesser risk of hypoglycemia, glycemic variability is also much lesser. So this triple drug combination acts on all the 5 glycemic pentad which we want our patients to be under optimal control. So if we see how effective the combination therapy is, on an average, it has shown to reduce fasting plasma glucose by 24 milligram, postprandial by 50 milligram, and HbA1c is decreased to the tune of 0.8 to 0.5 to 0.8% by individual drug. Glycemic variability is much lesser. So definitely there is improved quality of life because patient is not doing yo-yo between hyperglycemia and hypoglycemia. So, what is the clinical evidence for this triple drug combination therapy? So, this was a study which was published in Diabetes Care in 2014. It was a multi-center, randomized, double-blind, placebo-controlled phase 3 study where patients were intensified treatment with dapagliflozin as an add-on therapy who were inadequately controlled with DPP4 inhibitors with or without metformin. This included around 500 patients more than 18 years of age. These patients were on sitagliptin 100 milligram with or without metformin to around 1500 milligram per day. What they found is if you see here in this diagram on the right hand side, At 24 weeks, the HbA1c reduction was much better by 0.5 to 0.8% in patients on intensification with dapagliflozin. And the glycemic benefits were maintained throughout. What is important, there was durability to the effect of this triple drug combination therapy. Again, weight reduction in a patient who was on DAPA, CETA, and metformin combination was around 2 to 3 kgs. As against, if the patient is intensified on treatment with thiazolidinediones or sulfonylureas or insulin, definitely there is a tendency for weight gain. Again, this was another study which was published. This was again a multi-center randomized control trial which had three arms, fixed a combination of DAPA, CETA, MET. These patients were on sitagliptin or metformin or were on DAPA and metformin combination. And this was at the end of 18 weeks, they tried to study what was the effect. If we see primary endpoint, that is reduction in the sugar, it at week 12 and week 16, the first bar is DAPA, CETA, and metformin combination. If we see the HbA1c reduction in the first bar was much better at week 12 and week 16 in patients on triple drug combination. It was to the tune of 1.25 to 2%, as against a patient on CETA-MET or DAPA-MET combination, where HbA1c reduction was noticed to the tune of 0.8 to 1%. Again, when they tried to study if the fasting and postprandial glucose change was much better in this triple drug combination, we see in this diagram fasting sugar control was reduced by around 44 milligram per dl, as against post meal which came down by 60 milligram. So this triple drug combination definitely had a better fasting and postprandial class control. Again, weight wise, if we see this triple drug combination was much better as compared to dapamet or cetamet combination. So we have a therapy which goes beyond glycemic control. Nowadays, we don't just treat glycemia. We have to see, assess their cardiovascular risk, assess their renal risk, and accordingly, the treatment of diabetes has moved on from glucose centric to metabolic centric, cardiocentric, and renocentric approach. And that is why American Heart Association has now come up with a new terminology called cardio kidney metabolic syndrome. We just don't call it cardio renal or renal syndrome. So we need to address all the three issues in a diabetic patient. So we need a therapy that goes beyond just glycemic control. So there is this drug helps in works on multiple pathways. It helps in controlling the comorbidities associated with diabetes, because there is a single drug combination. The compliance improves. It has shown to have sustained benefit, and definitely this is a drug which does not have the risk of hypoglycemia and weight gain. Hence, patients are comfortable taking it. Now, coming to what is cardiovascular and renal safety data of dapagliflozin and sitagliptin. So, DECLARE-TIMI trial, cardiovascular and renal outcomes with dapagliflozin in CVOT trial, that was in DECLARE-TIMI. If we see, the red bar are the group of patients who are on placebo, as against the blue bar where the patients are on dapagliflozin. So, if we see in the diagram on the right hand side, dapagliflozin reduced the risk of CV death or hospitalization for heart failure. It reduced 3-point miss. It improved renal composite outcome, and it reduced the death from any cause. But most important thing was it reduced cardiovascular death and hospitalization for heart failure, and there was improvement in the renal composite outcome. And we all know that the major morbidity associated with diabetes is chronic kidney disease and heart failure. So, based on this, patients, the trial was conducted what is called as DAPA-HF trial, where they tried to study the efficacy of dapagliflozin in patients with heart failure, irrespective of their being diabetic or non-diabetic. They tried to study in patients with reduced ejection fraction, where EF was less than 40% and EGFR was more than 30. If you see here, there was 30% relative risk reduction in worsening of the heart failure. So definitely dapagliflozin did reduce the risk of hospitalization for heart failure. So this was the trial which was conducted in patients who had reduced ejection fraction. But in patients with preserved ejection fraction or mildly reduced ejection fraction, we don't have many options available for the treatment. So now dapagliflozin are the group of drugs even being prescribed in patients with heart failure with preserved or mildly reduced ejection fraction. DAPA-CKD study. So like DAPA-HF study where they tried to study the efficacy of dapagliflozin in patients with heart failure. DAPA-CKD was a study which was conducted in patients who had more proteinuria with EGFR more than 25, and these patients were this drug was used to reduce proteinuria in patients with or without diabetes. So now SGLT2 inhibitors are even approved for the treatment of proteinuria in a patients with CKD with or without type 2 diabetes. Again, if we see in this DAPA CKD study, they found there was 40% relative risk reduction in primary outcome, that is reduction in EGFR by more than 50%, progression to end stage kidney disease or renal or cardiovascular death. So they reduce these drugs reduce the risk of cardiac or renal event by 30 to 40%. Similarly, we all know that saxagliptin raised the worry about the use of DPP-4 inhibitors in patients with cardiac failure. So sitagliptin was studied in a TECOS trial to see whether it worsened the risk of hospitalization for heart failure, and it came out clean. So sitagliptin was not associated with an increased risk of hospitalization for heart failure in TECOS CVOT study. So that way, sitagliptin has been shown to be very safe. Similarly, Carmelina and Carolina trial also showed the safety of linagliptin. So, apart from saxagliptin, the risk of heart failure with DPP-4 inhibitors was not shown by any other group of gliptins. Now, coming to the clinical evidence for safety of this triple drug combination. So main thing is fewer patients who are receiving this triple drug combination need discontinued treatment or they need rescue treatment for failure to achieve glycemic targets. Again, adverse events where balance between groups and discontinuation rates were much lower. The risk of hypoglycemic event was much lesser in this group also. Now, we all know that whenever we are prescribing SGLT2 inhibitors to the patient, the risk of genitourinary fungal infections and UTI always bothers us. So, various studies have shown, when you're writing SGLT2 inhibitors in combination with DPP4 inhibitors, if we see the bar here, the risk of UTI or the genitourinary tract infections comes down dramatically in this group of patients. Again, coming to hepatic safety of SGLT2 inhibitors and DPP4 inhibitors, SGLT2 inhibitors do not cause hepatotoxicity. Again, in patients with mild to moderate hepatic dysfunction or child A, they can be eaten safely. Only thing is they are a bit catabolic. So if patient is not eating well or has lots of sarcopenia, then one has to be cautious in prescribing SGLT2 inhibitor in patients with chronic liver disease. Again, SGLT2 inhibitors do not need any dose adjustment in mild to moderate liver dysfunction. As far as DPP4 inhibitors are concerned, DPP4 inhibitors can be used without dose modification in patients with CTP-A. As far as vildagliptin is concerned, we all know that vildagliptin can increase SGOT and SGPT. That is why, compared to vilda, sitagliptin would be more safer when we have to write this group of drug in a patient with hepatic dysfunction. It requires caution in writing in those with class B and should not be used in patients with severe liver dysfunction. So we have a combination of Sitamet and DAPA fixed dose combination. So it's a perfect combination which achieves all-round diabetes management, like effective blood pressure control. This combination reduces weight. It is effective in glycemic control. Importantly, there is a lower risk of hypoglycemia. It is acting on a various components of homeostasis octane. It's a drug which offers cardiac and renal protection, and in addition, it is hepatorenal safe in patients with mild to moderate dysfunction. Again, the main worry when we are writing SGLT2 inhibitors is the risk of genitourinary infection. With this combination, in real world data, the risk of genitourinary infections has shown to be lower as compared to just writing SGLT2 inhibitors. So, who are the patients? Let us identify the patients who could benefit from this novel triple drug combination. So, patients who are on metformin and are uncontrolled, uncontrolled on metformin plus second glucose lowering drug. So, who is uncontrolled on metformin or with DPP4 and SGLT2, you can intensify with either drug, either SGLT2 or DPP4 inhibitors. So definitely, in patients whose HbA1c is more than 7.5 or 8.5%, we can consider using this triple drug combination. Again, obese patients with uncontrolled diabetes, as we said, when obese patients we write pioglitazone or sulfonylureas or insulin, it is going to worsen the obesity problem. In addition, GLP-1 analogs do help in weight loss, but we all know that GLP-1 analogs are very expensive drugs, not affordable to everyone. So if we have to look for a drug which will control the basic pathophysiology of diabetes, that is diabetes, obesity, this triple drug combination is definitely a good one because metformin and sitagliptin are more or less weight neutral, but dapagliflozin definitely helps in weight loss without increasing the risk of hypoglycemia. Again, as far as cardiovascular risk is concerned, sitagliptin is cardiovascular safe. It has shown not to increase the risk of hospitalization for heart failure. Metformin definitely is safe. And coming to DAFA, not only safe, but it has shown to reduce the risk of hospitalization for heart failure also. So the combination should be preferred over other conventional therapies in type 2 diabetes with established cardiovascular disease and or heart failure risk. Now, coming to patients with chronic kidney disease, sitagliptin we know that needs correction for the renal clearance, but overall it's a safe drug, does not have the risk of hypoglycemia. In addition, dapagliflozin has shown positive kidney outcomes in cardiovascular outcome trials and also in primary renal trials like DAPA-CKD study. So they can be used in patients whose GFR is more than 20 ml per minute per meter square. So the combination therapy, but when we are adding combination of sitagliptin 100 milligram along with DAPA-10 and metformin, mind you, sitagliptin can be used in full dose of 100 milligram only when eGFR is more than 45. So the combination should be preferred in a patient with type 2 diabetes with CKD but eGFR more than 45 when you are using sitagliptin in full dose along with DAPA and metformin. So we all know that all-round intensification is must to live well with diabetes to reduce the risk of complications. And we have a triple drug combination which can help us achieve this without the risk of having hypoglycemia, without leading to weight gain, and a drug which is more affordable and can be taken as a single drug in the morning.
Hello.
Yeah.
Thanks, ma'am, for wonderful session. Detailed session on fixed drug combination. Ma'am, there is a one or two question from audience. Question is if uh, patient having a HbA1c more than 9, so what is your drug of choice for this type of patient? Will you start a triple drug combination in this patient?
Definitely, HbA1c more than 9, as I said, will need triple drug combination. What kind of triple drug combination to choose depends on what patient profile we are seeing. But as I said, each drug will reduce HbA1c by 0.6 to 0.8%. So if our target is to achieve HbA1c 7, definitely these patients would need initially a triple drug combination.
Thank you, ma'am. And one more, ma'am. If creatinine clearance is less than 50, so in that this combination is useful.
So if eGFR is more than 45, we can use. In eGFR less than 45, basically sitagliptin needs renal dose adjustment. So the full dose of 10 by 500 by 1000 or 10 by 100 by 500 cannot be used because metformin will also need dose adjustment, and again sitagliptin will also need dose adjustment in eGFR less than 45.
Yes, ma'am. EGF, sorry. Thanks, ma'am. Only two questions are there from audience. So we will sign off, ma'am. Thanks for a wonderful session on FDC, ma'am. Thanks, ma'am.
Thank you.